Hello, everyone. I'm Lori Engler, Executive Director at NADF, and we welcome you to the Pediatric Adrenal Insufficiency webinar. I'd like to welcome today's presenters. Erin Foley-Moodry is NADF Board Vice President, and she led the work to create this webinar. We thank Erin for this great work and for everything she does for NADF. We welcome you. Dr. Mitchell Geffner is our featured speaker today, and he's a pediatric endocrinologist and so generous of his expertise and his time. I'd also like to thank Kalina Warren, who's been NADF's board president since 2012 and continues to show tremendous leadership and support across the patient and medical professional adrenal disease communities. A quick introduction to the National Adrenal Diseases Foundation. We inform, educate, and support those with adrenal disease and their families to improve the quality of life. Our goals are to stop death from undiagnosed Addison's disease, to improve the quality of those who suffer from adrenal disease, and to promote the study of adrenal disease to improve treatment and find cures. NADF helps to build strong, unified communities that work together to improve patients' lives and provide access to important life-preserving resources throughout their healthcare journey. And I welcome you all, and I thank you. Erin?
So just a little bit of housekeeping before we get started. Most of the content of this presentation is based on NADF's website. And that content has been written or compiled by NADF's medical director and our medical advisory team based on their extensive experience in endocrinology, as well as consultation from reputable sources such as the American Academy of Pediatrics and primarily the Pediatric Endocrine Society. We do like to note that NADF does not engage in the practice of medicine. We are not a medical authority and do not claim medical knowledge. In all cases, NADF recommends you consult your own physician regarding any course of treatment or medication. So as I mentioned, our medical advisory team, a huge thank you to them for all the work that they do. Our medical director, Paul Margulies, has been our medical director since the inception of NADF in the 1980s. And he is a clinical associate professor of medicine at Zucker School of Medicine at Hofstra Northwell out on Long Island. Dr. Spicer has also been with NADF for quite some time. She heads up our materials and our initiatives in the pediatric space. So a lot of her work is reflected in this presentation today. She is the chief of pediatric endocrinology, as well as a professor of pediatrics at the Cohen Children's Medical Center of New York, with her appointment at Hofstra Northwell School of Medicine. We also would like to acknowledge a contributing pediatric medical advisor for NADF, Dr. Nidhi Gupta, who is associate professor of pediatrics in pediatric endocrinology and diabetes at Vanderbilt University Medical Center, which has a wonderful endocrine center there. This presentation was also reviewed. The content was reviewed and contributed to by our guest today, Dr. Mitchell Geffner, who I will be introducing in just a minute. Just to quickly walk through our agenda for today, I am going to introduce Dr. Geffner, as I said, and tell you a little bit about him. And then he will walk us through an overview of adrenal insufficiency in children, treatment of AI in infants and children, some emerging and evolving therapies for children with AI, which we're excited to talk about. And then I will be walking us through, in partnership with Dr. Geffner, some questions that came from our NADF membership regarding pediatric adrenal insufficiency. And then Lori will close this out at the end. So, about Dr. Geffner. Dr. Geffner is the professor of pediatrics at the Keck School of Medicine at USC. He's also the former chief of the Center for Endocrinology, Diabetes, and Metabolism at Children's Hospital of LA. He's also appointed as the Ron Burkle Chair, Center for Endocrinology, Diabetes, and Metabolism, and is the co-director of the CAH Comprehensive Care Clinic. Lots of wonderful experience here, and we are really looking forward to hearing what you have to say today, Dr. Geffner. So I will leave it to you to take it away.
Thanks so much, Erin and Lori, for the kind words. And right now, we're just going to dive in and get started on today's topic of pediatric adrenal insufficiency. So it's important to start with some definitions and some background so that we're all on the same page. Now, adrenal insufficiency, depending on how you define it, is considered to be uncommon, although that may or may not be totally true, as you'll see. But regardless, it occurs when the cortex, or the outer portion of the adrenal gland, does not produce or does not produce enough of the key steroid hormone known as cortisol, which also goes by the name of hydrocortisone. These are one and the same, and sometimes that terminology is confusing because people jump between the two, but they are absolutely the same. In addition, in some cases, production of aldosterone is also affected. So as you can see on the lower portion of the slide on the left, there is a listing of what the sorts of things that cortisol does. These include mobilization of nutrients, modification of the body's immune system as it relates to inflammation and stress. Cortisol plays a vital role in maintaining normal blood sugar via action upon the liver. And this is why cortisol is sometimes referred to as the body's main glucocorticoid, and that has to do with its glucose raising or blood sugar raising effects. Cortisol also helps to control the amount of water in the body. And if you don't have cortisol, you'll have extra water in your system. Aldosterone, on the other side, plays a primary role in balancing your sodium and potassium, and secondarily your water volume in the body, and that in turn regulates blood pressure. Next slide. So shown here is what looks like a very complicated sort of chart, but I'm going to simplify this greatly for you. And really what we're going to do on the next few slides is look at the different types of adrenal insufficiency that occur in children, some of which is also true in adults. And we're going to refer to this as initially for the what's on the upper left as primary adrenal insufficiency, or PAI. So primary refers to the fact that the problem lies within the adrenal glands in the sense that there can be various types of medical conditions that affect the adrenal function, which we will talk about in a minute, or there could be injury through trauma sometimes to both adrenal glands, or surgical removal of the adrenal glands for some other reason. This would all lead to primary adrenal insufficiency. And in most cases, that would involve cortisol and aldosterone. If you flip over toward the right on the top, you'll see the other subcategory called central adrenal insufficiency, which refers to some problem in the brain, and in particular, either the pituitary gland, which is the source of ACTH, which is the sort of primary driver of cortisol production, or CRH, which stands for corticotrophin releasing hormone, which is the stimulator of ACTH. So you can't have ACTH without CRH. So there's possible medical conditions that could affect one or the other or both. In that case, there will not be the appropriate signal to the adrenal gland, and there will then be decreased cortisol levels, but aldosterone function will be normal. And so you see on the center part of the chart how we're going to break this down into different causes of primary adrenal insufficiency on the left and different causes of central adrenal insufficiency on the right. And you're going to see on subsequent slides, starting with the next one, a bit of a blow up of these sections, and in turn followed by some slides that discuss these entities. So you can see here for primary adrenal insufficiency, or PAI, there's three major causes in childhood that we are going to discuss in more detail shortly, but these include Addison's disease, congenital adrenal hyperplasia, and X-linked adrenal leukodystrophy, or ALD for short. We use lots of abbreviations, but I'll try to not do that here. And then we'll talk about different types of CAH, congenital adrenal hyperplasia, also in a moment. So let's start off with Addison's disease. This is the primary cause of adrenal insufficiency, of primary adrenal insufficiency in adolescents. And Addison's disease, technically speaking, is an autoimmune disease, meaning the body attacks a part of itself that up until a certain point there was no attack, and it's as if the adrenal glands were transplanted into the body, and the body says, I don't like these because they're not mine, and it starts to reject them as if it were a mismatched transplanted organ. And the way the body does this is it uses what's called the cell-mediated arm of the immune system, or specifically T cells that initiate the attack on the adrenal cortex. And interestingly, it's just the cortex, not the other part of the adrenal gland known as the medulla. But as a result of that, there is a destructive process that can be quick or sometimes more insidious or slow, resulting in the loss of cortisol and aldosterone. Now, the way this diagnosis is made is by the measurement of antibodies to one of the enzymes within the biochemical machinery in the adrenal cortex. These antibodies are mounted and they can be detected on a blood test. But the antibodies themselves do not actually cause the disease. They are markers for the disease, but very helpful in making this diagnosis. And this is a disease that was discovered way back in 1855, if anybody likes history, I'll just throw that in there, by a gentleman named Thomas Addison, not to be confused with the gentleman who invented the light bulb. That was Edison. But when that was first discovered, Addison's disease was caused or thought to be caused by tuberculosis. And over time, this has shifted. And now the term Addison's disease is used strictly for the autoimmune form. And if you're deficient in cortisol and aldosterone, you may have a bunch of symptoms that ultimately lead to the diagnosis, but oftentimes that the diagnosis is delayed. These include salt craving, which is related to the lack of aldosterone, but also general things like vomiting, weight loss, abdominal pain, weakness, fatigue, vague kind of pain and anxiety. And as I think most people know, without proper diagnosis and treatment, an affected individual, a child or adult, can have an acute life-threatening crisis. And if this diagnosis is confirmed and made, it can occur by itself with no other medical conditions, but there is going to be a heightened risk for other endocrine-specific autoimmune conditions, such as involving the thyroid gland or type 1 diabetes or certain other things. Next slide. In terms of more information about CAH, congenital adrenal hyperplasia, this is a genetic disorder. And in childhood is the most common cause, in fact, of PAI. And fortunately, is usually diagnosed within the first 1 to 2 weeks of life, because there is newborn screening for this in all states in the United States and in many Western countries. Now, there are 3 types. There, as you can see across the top there, and one is called classic salt wasting, and that is the most common form of the classic variety, but there is a non-classic variety, which is the title of the box to the right, which actually of all of them is the most common. But of the classical form, the salt wasting is present in about 3/4 of cases and is associated with deficiency of both major steroid hormones. And as with any other type of PA, if not recognized and treated quickly, life-threatening crisis can occur. But with newborn screening, in most cases, this no longer occurs, which is one of the fantastic benefits of newborn screening. Girls who are affected with this will be exposed in utero to elevated levels of male hormones, which will cause their external genitals to be somewhat male-like in their appearance. And that by itself is a clue to this diagnosis. Boys, on the other hand, often will have no outward physical findings of the genitals, although possibly an enlarged penis. But that's sometimes a very tough physical finding to be sure of. So newborn screening, in effect, is really more for the boys, because it's otherwise not so easy to make the diagnosis. But again, any infant who is not diagnosed or treated properly can have the sort of progression of symptoms from vomiting, weight loss, dehydration, shock, and even death. But again, with newborn screening, the odds of this type of outcome are much reduced. In the second box, you have the classic or non-salt wasting form. This represents the other quarter of cases of CAH. And this is also referred to as simple virilizing, because the only physical findings that are clear-cut occur in girls with the masculine looking external genitals, but these children are not prone to the severe salt wasting crisis. But unfortunately, once again, this diagnosis is detected on newborn screening. And the non-classic, or what used to be called late onset form of this condition, abbreviated NCAH, of all is the most common. And depending on the population, it may actually be one of the most common genetic diseases known to mankind. It does not present at birth, but will be triggered by usually early pubertal changes that occur related to excess male hormones. The cortisol deficiency is relatively mild, and in point of fact, not all children or individuals with this condition need to be treated, and even those that require treatment in childhood may not need to take any medication after puberty occurs. And a word or two about X-linked adrenal leukodystrophy, or ALD. This is a rare genetic disease. It occurs, as you can see, in about 1 in 15,000 to 20,000 males. It's extremely rare to occur in a female. And this is a very serious medical condition that causes progressive neurological abnormalities, and can, if not recognized and treated correctly, lead to early demise. And this is due to a genetic problem that leads to the accumulation of what are called very long chain fatty acids, or VLCFA, and doctors talk, that are poisonous, if you will, as they accumulate, particularly in the sheaths, or the outer portion of nerves in the brain. But they also accumulate in the adrenal gland, causing it to underfunction. And in males, I say males because that's who gets it, but can also cause testicular damage. It may not become clinically apparent till 4 years of age, and by that time there can be permanent effects. But fortunately, there is now an evolving newborn screening for this. And I'm not exactly sure how many states have it, but there are several, and I'm pretty sure that all will have it in the near future. Of course, the adrenal insufficiency part of this needs to be recognized early, and can occur actually in infancy, although typically starts later. But the early recognition of this condition is important, because there can be treatment through bone marrow transplant, actually, that is better. The outcomes are better if done earlier. There was a medical therapy for this that was tried for a while, known as Lorenzo's oil, and a movie by the same name, who starred Nick Nolte and Susan Sarandon, if anybody's interested in that. It's an excellent movie, but bring tissues. Next slide. So if we move to central adrenal insufficiency, that can be divided up into two types: secondary or tertiary. And I will define those for you in a moment and go over the various causes starting on the next slide. So when you have secondary adrenal insufficiency, that refers to a problem lying in the pituitary gland, which is the source of ACTH. This can be affected by various things that affect the pituitary gland development, actually genetic disorders, so that this results in a deficiency of ACTH, in fact, at birth. But usually it does not occur in isolation, and that there are other pituitary hormones that would also not be functioning, such as growth hormone. But there are other causes for this that occur later that cause an acquired form of secondary adrenal insufficiency. So that can be from pretty much anything that affects the pituitary gland, including tumors or infections. And this collectively might be called hypopituitarism or multiple pituitary hormone deficiencies. The tertiary form on the bottom refers to when the underlying problem lies further up in the brain in what is called the hypothalamus, which is the controller of the pituitary gland. That is the source of the hormone that I mentioned earlier called corticotrophin releasing hormone, and that is the stimulator of ACTH from the pituitary, and which then in turn stimulates the adrenal cortex. So the most common problem that occurs here is one in which patients with various types of non-endocrine diseases, for example, as you can see there, rheumatoid arthritis, severe asthma, it could be inflammatory bowel diseases, many. They are prescribed high doses of the glucocorticoid, usually things like prednisone, and then they do better after taking that for a while, and the medication is stopped. But while they were taking it, it suppressed their own body hypothalamus from doing its thing. And it takes a while after you stop the medication for the hypothalamus and secondarily the pituitary gland to wake back up. And so one is theoretically in a risk for adrenal insufficiency by that mechanism. Next. So how do you recognize adrenal insufficiency in children? And this is really important because there are lots of stories, some very sad, in which the child goes to doctors and the diagnosis is missed, and then there's a catastrophic outcome. So, and that's because a number of the symptoms are very vague and they're not specific. But if you have primary adrenal insufficiency, one of the things that will happen even in fetal life, if this is evolving, is that there will be a darkening of the skin and the mucosal surfaces, in particular places like the elbows and the knees, and inside the mouth on the lips and the tongue and the gums. And this is due to the pituitary gland recognizing that there is low cortisol output, and it makes, as we've been talking about, extra ACTH to try to fix this, but it also there's another hormone that's made that is called melanocyte stimulating hormone, that is the hormone that's responsible for the skin darkening, and that needs to be taken seriously. In addition, low cortisol can be associated with low blood sugar because you're missing that glucocorticoid effect that I mentioned earlier. And then you get sometimes some vague things, some jaundice, yellowing of the skin and the whites of the eyes, poor weight gain. Some of these are maybe relatively vague. If you are deficient in the mineralocorticoid aldosterone, then your salt level or sodium level in your blood drops, your potassium level goes up. If the salt level goes down, it's because you're peeing it out, and water will follow the salt, and that's how you can get dehydrated and go into shock. When you have CAH, unlike other causes of adrenal insufficiency, you are at risk if the disease has not been diagnosed for whatever reason, or if it's undertreated, for ongoing effects of extra male hormone, which can range from things like pubic hair to, in girls, ongoing enlargement of the clitoris. If you look over to the right in terms of commonly presenting features across the various types of adrenal insufficiency, again, on the left-hand column, it's more of the vague things, although as you go down that list and then kind of go up to the top of the right, you start to get a little more serious, from dehydration to low blood pressure. When you're mineralocorticoid deficient, because your salt or sodium level is low, you will crave salt. And if you're even on medication but still craving salt, the replacement medicine, which is fludrocortisone, that dose may not be enough. And then again, the tanning or dark skin should be noted, and it's of more significance if somebody's getting dark skin and they haven't been out in the sun. A lot of times it's just described to, you're outside in the sun and you get a tan, but this is different, and there's no tan lines here. So it's important for parents and physicians to be aware of this. So how does one diagnose adrenal insufficiency in children? Well, first you have to have the clinical suspicion based on all those symptoms and things that we've just been talking about. And then the appropriate lab tests need to be ordered, which would be cortisol and probably aldosterone in most cases. Sometimes an ACTH level is actually measured because in primary adrenal insufficiency, it will be elevated while the cortisol and the aldosterone will be low, but in the central form, the ACTH will be low, the cortisol will be low, the aldosterone will be normal. Sometimes, though, even though that seems perhaps rather simple, additional blood testing to sort of ferret this out is required, and there's something that is called an ACTH stimulation test, or also known as a cortisol stimulation test, where you're blasting the patient with high doses of ACTH. There's no harm in that, no side effect, but you're really hitting the adrenal glands to see what their ability to respond is. And if the output of the hormones are low, then you have a more firm diagnosis. Sometimes the radiology department is important. If you are looking for the etiology and if you know it's in the adrenal glands, but you don't know what it is, sometimes doing a CT scan of the adrenal gland will be informative. If you know it's central, meaning it's coming from the brain, then an MRI of the hypothalamus and the pituitary is mandatory. And then there's a few other clues sometimes. Of course, if there's a family history of adrenal insufficiency, then that, depending on how that's inherited, or if it's inherited, that will be a clue. If there is CAH in a family, the diagnosis can be made in utero, certainly suspected from ultrasound and confirmed biochemically or genetically from studies of amniotic fluid. Physical examination certainly will give clues, and then sometimes genetic testing is required depending on what is found with all the other tests. Let's move to treatment. Some general sort of background here related to current practices. This is information that was reported in guidelines from the Pediatric Endocrine Society. The first thing that was reported there is that they found via survey that hydrocortisone is used in the treatment of pediatric adrenal insufficiency in either 2 or 3 divided doses per day, and we can talk about that later. And for those who have aldosterone deficiency, fludrocortisone, usually given once a day, is required to maintain normal salt and fluid balance. Now, in a survey from 2015 of pediatric endocrinologists in Europe, they found that 1 milligram or 2 milligrams were the most common doses of hydrocortisone used in infants and newborns. Which is interesting as to how they got those doses back then. More on that in a moment. And they uncovered, the fact that caregivers, some of you parents out there, were trying to be, clever. And in order to give such kinds of doses, tablets were being not only crushed in half or split in half, but in quarters. I even have a patient who does somehow a 1/6, and I don't know how that happens, but that's what she tells me. And then in a small study from the UK in 2018, they concluded that because of these practices, there is a risk of under or overdosing an infant or a child, not uncommonly. Next. Okay, so what about the concept of stress dosing or sick day dosing, terms often used interchangeably? Someone without adrenal insufficiency, if they get sick or they have surgery or they have an injury, they make more hydrocortisone automatically. If you have adrenal insufficiency, you are unable to do that. Now, you are taking medicine on a daily basis for sort of, normal life situation. But if the child or the adult gets sick, and the sicker that they get, the more risk of a problem is if stress dosing is not applied. What are these stresses? They're generally medical stresses or trauma. And so you see fever, bad diarrhea, vomiting, surgery. You don't see on here things like taking exams at school or sporting events that might be a form of stress, but that's not usually a situation where stress dosing is recommended. And if, upon recognition, then you will be familiar with things like double oral dosing or triple oral dosing. And if those are tried, or if the child is really, really sick rather rapidly, then that requires the administration of intramuscular hydrocortisone, and more than likely a trip to the urgent care or the emergency room, even if the child responds. Each child's endocrinologist, hopefully out there, has spoken to families about this, provided specific instructions, even in the form of a letter. The current form of emergency hydrocortisone given intramuscularly, can also be given intravenously, but not obviously at home, is called Solu-Cortef, also known as hydrocortisone sodium succinate. And this should be available to all parents. And a whole nother conversation is what emergency medicine or emergency medical technicians are allowed to do, but that's for a different discussion. But this medication can be life-saving, and I think that's the main point. So what's coming down the pike? So there's a few interesting new things, and I would tell you there haven't been new things for AI in terms of treatments in a long, long time. And so I think this is an exciting moment for patients, families, and their medical teams. So one area involves the use of long-acting forms of hydrocortisone, as well as hydrocortisone administered by a pump. More on those in a moment, but I'll preface my comments that these are under study and not yet approved for pediatric use in the United States. What has been approved is the new formulation of hydrocortisone in the form of granules. Again, we'll talk briefly about that in a moment. And this is here on the market. So as far as the longer acting formulations of hydrocortisone replacement that are being investigated, they include medications known as Plenadrin and Chronocort. These are single dose forms of hydrocortisone that differ from what's on the market by certain characteristics that they have in terms of, in some cases, a more rapid peak or rapid absorption, as well as a longer duration. And there's slight differences between these drugs, and they are approved on the other side of the Atlantic for adults. Pump therapy would be similar to the way insulin is administered to folks with diabetes. In fact, it would be an insulin pump, but wouldn't contain insulin, and rather would have Solu-Cortef. Now, this is not yet approved in the United States. It is approved in several European Union countries in adults, and is being studied, and is also being used, if you will, off-label in the United States. I've seen a few children who have been taking their medication this way. You might ask why, and that has to do with some folks, this is more data from adults, no matter how they take, multiple oral doses, they just don't feel right. And when this could be more physiologic, more able, because you can change the rate of administration to match the normal circadian rhythm. There are also some people who just cannot tolerate oral hydrocortisone. It irritates the heck out of their stomach, and that might be another situation for consideration of use. I don't think this is going to be by any means for everybody, but it might be for people who are struggling. Next. The new formulation, the granules of hydrocortisone, are known as Alkindi Sprinkle. People want to say sprinkles, but for whatever reason, the naming of this is in singular. There's no S. But this came on the market in the States in 2020 via Eton Pharmaceuticals, and previous to that is Diurnal, it's the name of a company. And the approval was based on the results of 6 clinical studies in patients with AI, including CAH, who were under the age of 17, all the way down to infants. And the idea behind this is it allows the accurate provision of low doses of hydrocortisone. And that includes, as you can see on the bottom right, formulations of 0.5 milligrams, half a milligram, 1 milligram, 2 milligrams, and 5 milligrams. This is how the medication is packaged, but that's not what goes into the body. You have to actually, in a sense, break open the capsule, and the granules are in there, and they can be placed either on a child's tongue or cheek. Cheek seems to work better in babies. In someone slightly older, you could use a spoon, or you could disguise it in applesauce or yogurt. And this is going to allow much more accurate dosing, which at low doses, which is often or more often confined to infants and younger children, but may have some application in older folks. And as far as new ways of delivering emergency hydrocortisone, that's what this slide is designed to tell you. So right now, what you do is you have Solu-Cortef. It's a 2-chamber cartridge that you have to sort of twist and mix and then withdraw and inject, and a needle is involved. So these two new developments that are not on the market and are probably not going to be on the market for several years will allow hydrocortisone to be administered without a needle, but rather by something called, for simple purposes, jet injection. And it's just pushed through the skin. And the Zeneo product, which is the injector itself, is actually on the market in the United States for administration, not of hydrocortisone, but of a drug called midazolam, which is a sort of like a Valium derivative that is used for emergency treatment of seizures. So the technology works. It's just a matter of, for that anyway, it's just a matter, I think, of testing it for hydrocortisone. And the advantage here is, as I hope not too many of you know, but if your child or yourself is having an adrenal crisis, it is really stressful. And sometimes it is hard to find the Solu-Cortef. Or you find it, but where did I put the needle? I was taught 5 years ago, but I don't remember right now. So these are very stressful situations, and this will make the administration much easier. The newest company that I'm aware of not on the market, but in the testing phase, is called Solution Medical, and they have something that will be called, I guess, TwistJect. And again, it's a much more simple process for administration, which I think is needed under emergency circumstances. Next. That's the presentation, the formal presentation, but upcoming, I think we're going to do some Q&A.
Thank you so much, Dr. Geffner. So informative and great useful information in there. In preparation for the development of this webinar, NADF surveyed our members and collected responses from members with children or who care for a child or adolescent with adrenal insufficiency. And the main question we ask them is simply, what are your greatest concerns and challenges about caring for a child with adrenal insufficiency? And what I'd like to do now is ask you a few questions based on the responses to that question, starting with the biggest concern of our respondents, which is fear of adrenal crisis. Parents are fearful, caregivers are fearful that a crisis could happen at any time. They have worries that they're not giving the right balance in terms of hydrocortisone dosing to avoid a crisis. And there's a lot of ambiguity and fear around understanding how to recognize that my child needs a stress dose, especially in your younger kiddos who can't voice that. So if you could talk a little bit about that would be great.
I'd be happy to. I'm not surprised by that question. That really should be the primary concern. As you indicated, the age group that it's most susceptible to adrenal crisis, hospitalization, are the infants, because again, it's just what you said. As you get older, and the child, or as the child gets older and can verbalize, and things become a little more crystallized. So, but regardless, it can happen at any age. Now, usually it doesn't happen completely out of the blue. There's some trigger. Most commonly in children, that's going to be just some infection that causes, one to throw up or have diarrhea, where the medicine, the normal oral dose of medicine, even if you can get it in, doesn't necessarily stay in, or comes right out, or goes out the other end. So, but just, you come home from school and you're perfectly fine, you're probably not going to have, in most cases, an adrenal crisis. It'd be unusual. Now, recognition is a number of the things that I said, and again, they're sort of just the basic signs of illness. I always say to parents, if you think that your child needs a stress dose, if it crosses your mind, you should do it. That could be an oral dose or even the injectable. It's very rare that you would actually do harm by giving extra short term than by not. And so that's why I kind of say it like that. You might think that's bold, but I think it actually makes sense to do it that way. And then, I'm sure you've been taught, various ways of sort of double oral dose for mild stress, and triple oral dose for a more significant one. But as soon as there's vomiting, then the injection really should be given. And if the injection is given, as I alluded to in the talk, you can't be 100% sure it's going to work. I mean, or it's going to, work, may only work for a certain amount of time. So I always tell parents, when you give it, there needs to be a medical visit that follows that, and also a refill of a prescription if need be, so you're not left without any. That's my general approach. I think if you end up in the emergency room, I don't want to jump a question here, but I know one's coming. So it's always good for you to have in your possession for your child a letter from your doctor that explains the condition and what should be done in emergencies. Now, I mean, I've seen some emergency room doctors don't want to see that because they think they know everything, but I would still wave that in front of them as an attempt to be an advocate for your child. I hope I answered the question and I didn't deviate too far off.
Yeah, no, that was great. Let's talk a little bit about concerns with over medicating. I wouldn't say overdosing, I would say over medicating. Right. And as a parent, I might be concerned about the side effects of over medicating with hydrocortisone, and what are the effects of that? Are there truly side effects? Can it affect a child's growth? That is the second biggest concern of our audience.
Yeah, and again, rightfully so. So the answer to that is there can be many side effects if one over medicates. That is prescribed or takes too much. Now it's going to be dependent on how much over medicating. You know, if it's 1 milligram, which it's not going to be, but you know, if it's twice what you should be taking versus, I don't know, 10% more than what someone else might give, you know, the higher the dose, and the longer the duration, the more likely there are side effects. Now we try to get the dose right. The dose is constructed around the size of the child or an adult. And we will often do this by calculating something called the child's body surface area, which is related to their height and weight. And we know that a body, when it's working normally, or adrenal glands, when they're working normally, will produce about 7 milligrams per meter squared per day. So a child of 66 pounds is 1 meter squared. You can do the math off of that. The bigger you are, the more you need. So then when we calculate the number, then we have to decide how are we going to distribute it. And that gets to the guidelines that I mentioned earlier, be it 2 or 3 doses. I'm going to be bold for sure. And I'm going to say I rarely use 2 doses. And this doesn't matter what the cause is. And the reason for that is that when you take an oral dose of hydrocortisone, it only lasts for 6 hours. So if you're taking 2 doses a day, well, you'll have coverage for 12, but you won't have it for the other 12. Now, I rarely, so in theory, it should be given every 6 hours, but it's very hard to get compliance with that. So we kind of cheat a little bit and we give it every 8 hours. So that's usually the interval. And then the question is, how do you split it up? I've seen where you follow the way the body normally does it, and you give like maybe half of the dose in the morning and a quarter at the other 2 times. I've seen some cases where it's distributed evenly. In a baby who is newly diagnosed, you can split it evenly because there is no circadian rhythm that occurs until 6 months of life, so it doesn't matter. And then in CAH, it's a little bit trickier. Some physicians will actually prescribe the distribution in what's called a reverse circadian manner. That is where you might give half the dose at bedtime and the other 2 doses morning and afternoon, a quarter. The quarter, there's different folks do it different ways. So that's sort of how you play with it. And then so it starts that way, and then if you over medicate, the main effects of that, if it's sustained, will be slowdown in height velocity and an accumulation of weight out of proportion to what the child eats. And so it has effects on both of those. Over time, it can, I mean, if it goes on and on and on, you can develop osteoporosis. It can affect your immune system and its ability to fight infection. So there's lots of things, and you don't really want to let that happen. And I don't think it happens that often if one receives, solid medical care.
That actually is a good segue into a question that did surface. It wasn't really in the top of our parental concerns, but it did come through clearly from a handful of those surveyed, is when you've been on a higher dose or maybe it's not that high, but if you've been on a long-term dose of hydrocortisone or steroid for one of the conditions that you mentioned are often treated, not endocrine conditions, but things, like irritable bowel syndrome and asthma and some other things where they're really looking to get that anti-inflammatory property that steroids offer. But then you end up with a kid or an adult person who their adrenal glands think they don't need to make the steroid anymore because it's being given to them externally. So can you talk a little bit about how that happens, why it happens, and what can the patient and their family expect when this is discovered that their adrenals have been suppressed? What's the pathway to overcoming that and reversing it look like?
Sure. So this is actually fairly common. First of all, because there are many diseases that both you and I briefly mentioned, in which high doses of glucocorticoid, usually it wouldn't be hydrocortisone, actually it would be prednisone probably if it was taken by mouth, but same idea. But it also can be from inhaled steroids that are used for asthma if not taken properly or too high of a dose. It can be from someone who has rheumatoid arthritis who gets repeated injections of some sort of synthetic glucocorticoid into their knee. So it can be for many directions. That's first of all. So second of all, the likelihood of being adrenally insufficient is usually going to happen after the medication is stopped rather than during it, because during it, you're usually taking high doses to start with. So it's less likely to happen while you're still on it. But after, until your adrenal glands, or really your hypothalamus, and then your adrenal glands wake back up, that's the risk period. And most of these patients, again, as we've said, are not seen by endocrinologists. They're seen by rheumatologists or gastroenterologists. And they all have their own different ways of doing this, but sometimes they will taper. Let's say if it's a prednisone dose by mouth, they won't go from 30 milligrams of prednisone to 0 in one shot. They'll try to do it gradually. So as the dose goes down, it allows recovery. And I think in most cases it works, or otherwise we'd be hearing about this, but sometimes it doesn't. And again, if you would be looking for the same symptoms, not the darkening of the skin, but the sort of general symptoms, if they were to evolve would be the clue. And how long it takes to recover is related to the dose that was used for the treatment of the primary disease and the duration of that treatment. So if that duration was years, it could take a year for there to be recovery of the adrenal glands. If that was for a month, of high doses, it's going to be a lot quicker. And it varies from person to person. So sometimes what will be done is you can have measurements of your cortisol done sequentially, once a month in the morning, after you've been off these medications, to see what the levels are to make sure it comes back up. And that's rather than just sort of saying, oh, it will come back, don't worry, and which I've heard some doctors tell their patients. So you can actually, monitor for this and be more secure scientifically.
Great. Thank you for that. I know there's that seems to be a question that's surfacing more and more to us, posed to us at NADF. So I think one more topic that is really important that was also surfaced as a concern, not surprisingly, from our audience. It's a concern of mine personally. It's a big concern for NADF as an organization. Is there's an extreme lack of knowledge in the general medical community about adrenal insufficiency and how to treat it, especially in emergency situations. And I know that you touched on a few minutes ago the need to carry a letter, say, from the child endocrinologist, so that when you show up in the ER, you have some backing and credibility. But can you talk a little bit about that lack of medical community understanding, and what are some things that we can do as patients and parents of patients?
Well, it's a real phenomenon. First of all, this is why people brought it up, because they either are afraid of it or they've encountered it. The letter is helpful, although again, some doctors sometimes, in that situation don't want to see that because they think they know everything. But the more things that the patient has that are official, like the letter on letterhead, medical alert bracelet, that's registered, is another valuable thing to have in terms of providing, validation that this is, you're not making this up, or why would you make it up? But, and then, the education piece that I think that's hard. I mean, we in an academic institution like Children's Hospital of LA and like the ones that your advisors belong to, I mean, we give lectures to the emergency room people. They get a lecture on seizure management. They get a lecture on adrenal insufficiency, on diabetic ketoacidosis. So we try there, but it's the physicians, I think, in the emergency room in the smaller hospitals that don't have that kind of access that probably should be the target audience for any educational initiatives, which maybe is what I'm hinting at here, from organizations like yours, to try to sort of get on the schedule when there's meetings of emergency medicine doctors, right now, of course, it would be by Zoom like this, but try to get out there. But in the end, the patient and really the parent is going to have to be the advocate. And even if they have to scream bloody murder to get things taken care of the child. And if your child's in an adrenal crisis, when you go to an emergency room, what you don't want to have happen is, the triage process says, okay, there's 10 people ahead of you. Okay, you need to be number one unless somebody's having a heart attack. There should not be, and that should be in the letter, because there can be rapid evolution from whatever you're seeing to a worsening clinical situation. Which, if that happens while you're sitting in the emergency room, that is just about the worst thing possible. So you really have to yell loud, sometimes literally, to make sure that your child is triaged appropriately and rapidly, just because the crisis can move quickly sometimes.
Yeah, we have unfortunately heard a lot of stories NADF about people who end up dying in the ER because of exactly what you're saying, and it's an unnecessary, horrible problem. I know that for myself, having lived with Addison's now for over 28 years, if I need to go to the ER, I call an ambulance, because you're then right in on a stretcher, and at least you get more attention than if you go walking in. That's something that I have found helpful. And also we have a lot of members who I know they'll inject first and then go. And
absolutely,
it's overcoming that fear of injecting your child is huge for parents to become comfortable with before there's a crisis, because it is going to be stressful, and under stress, you tend to kind of forget exactly what you were saying. How do I use my active vial? How do I draw? How much do I inject? Where do I inject? So we actually, NADF has some great resources on emergency injection on our website. And we also have, you can request an emergency wallet card, which can supplement your child's medical alert bracelet that you can keep in your wallet or stick one in their backpack. I mean, all kinds of uses for that. And then I also just want to mention that the education of the emergency folks is something that we've been working on at the nursing level. We have had the speaker at Emergency Nurses Association a few times, and we're trying to grow that program in the next year or so. So we're working on it. It's a big thing to tackle. But I think now we're going to have Lori close us out. I want to personally thank you, Dr. Geffner. It's been wonderful working with you on this project, and your expertise is so very much appreciated.
And Dr. Geffner, Aaron, I thank you both so much. We all do. The session was filled with so much great information. I know that those that are watching may want to listen to the recording several times. I know I probably will, because I think you'll learn something new with each viewing. So to find the recording on the NADF website, if you don't already have the link, it's www.nadf.us. Just to make it easy to locate, look for the link in the Tools for Life tab, and then you're going to see a children's section. There's so much great information in that section, and one of the things that is going to be there for you is the link to this webinar. Share it, watch it, and I also want to say, let's all do our part to continue to build adrenal disease awareness. I thank you all.